Dr. Perumalswami. Take it away.
All right, thank you so much, Dr. Das and Dr. Ward and the rest of the organizers for the invitation to share a little bit about work on behalf of our group. My talk today is entitled Community-Based Interventions to Address Health Disparities and Advance Hepatitis Elimination. So I hope to touch on some of the principles that I have found very useful in community-based work, and also share a little bit about how it came down the path that I've gone. I don't have any disclosures, and I think, as we just heard from Dr. Perez-Stable, we certainly have the tools. And so I think the question still remains, why haven't we solved the public health issues around hepatitis B and C? We certainly, as you just heard, know how to prevent, diagnose, and treat, but not everyone has been reached, and disparities exist. Stigma and discrimination, unfortunately, remain big problems, and so gaps remain. And there are a number of evidence-based community interventions that you're going to hear from myself and the other panelists and speakers around testing linked to care, treatment, and how we do this in different settings. And I think one of the principles I'd like to start and also leave the audience here with is this concept of what still needs to be done. I would argue we still need to continue to advocate for increased funding for research and programs and activities, and to continue to engage our communities and think about how we implement and study implementation and then scale our interventions. My part of this talk today is really going to focus my work around hepatitis B with our community partners. I'm a hepatologist. I'm not married to any one virus here when we're talking about viral hepatitis. But we know that there are a lot of disparities, as you just again heard, and that the majority of Hep B infection in the United States is really shouldered in our foreign-born populations. And we've certainly seen a rise over the last several years in the number of Hep B cases, particularly in people with opioid use disorder, and that a lot of the disparities, again, have to do with stigma, discrimination, a lack of awareness and education, thinking about health-seeking behavior and how this is different in the communities that remain at risk. And what I mean by that is, some communities certainly are driven around prevention and symptom-driven behaviors in terms of when they seek help. Versus other communities, it's really only symptom driven. And we know that with these viruses that are largely asymptomatic, that by the time symptoms do develop, if they're related to this disease, it usually means that the disease is quite advanced and our treatment and care options become much more limited. We want to get to patients earlier. And certainly another barrier that still exists include those surrounding access to care. And that might include things like a lack of insurance, language barriers, health literacy, and transportation. A lot of my work has focused on hardly reached populations when I think about viral hepatitis, and thinking about how we scale up testing, linked to care, and engagement in these groups. I do think that language matters, and for, I would say, quite a long time, too long of a time, we've often described our communities that are at highest risk for these viruses, often as terms like difficult to engage, hard to reach, special populations, which I think only adds to stigma and creating barriers. And thinking about how we scale these activities within communities and build ties and develop relationships that are bidirectional, and think about how we do a better job of breaking down silos and integrating care. So with that in mind, really my activities in the viral hepatitis space certainly have been focused on how do we increase provider capacity, particularly on the frontline provider capacity to reach people living with viral hepatitis, and how do we identify the determinants to viral hepatitis screening and care, and really focus on redesigning and focusing our solutions to barriers at the system and provider level. I come back to this framework quite often. It was developed by the CDC along with a number of other institutes and programs, and this is the continuum of community engagement. And what you can see on the left side are what I would say probably lower levels of community engagement, and that really thinking about, for myself, it's been very helpful to think about this framework and how I continue to push what we're doing towards the right on this figure. So really push it towards collaboration and shared leadership. And I think in order to have a wider impact and developing deeper ties to communities, this has really been a nice framework to really try to embody in the work that we're trying to build, because this enables bidirectional relationship, really helps build trust, and really build deep ties to the communities that we're trying to reach and serve. The evidence-based intervention that I have focused, my activities around have been around community health worker-led models of viral hepatitis outreach. We know that there's been really just an explosion or growth of evidence around community health worker-led models of care. And thinking about public health workers or community health workers trained in this way to really bridge the gaps between health systems and communities has been helpful. And we know that the evidence is quite strong in terms of systematic reviews, thinking about chronic disease management and strength of evidence in randomized controlled trial, and some limited work also, as we've discussed, in terms of a lot of our foreign-born populations. There was a nice systematic review published several years ago looking at this model of care in API communities, or Asian American Pacific Islander communities. And the top 3 diseases included cancer, cardiovascular disease, and hepatitis B. But there still are a number of communities, I would say, that where this model has yet to be leveraged, or has been leveraged in a very limited way. Which was really kind of the kernel or the proof of principle when I first started thinking about how to develop a community-based viral hepatitis outreach model back in 2009, which we later called Hepatitis Outreach Network. So thinking about how we train and recruit community health workers to really help us develop these models, to engage community partners, particularly our foreign-born communities that are at risk for viral hepatitis, and engage our partners, implement navigation strategies, offer education, testing, and link to care, and have a community health worker embedded in all of those activities. And in the first 2 years of this outreach, viral hepatitis outreach model, we were certainly able to find and not only just test a lot of people for hepatitis B and C, but find people with living with chronic infection who had not yet been diagnosed, and get more than half of them into care, and most of them into and onto treatment, along with kind of long-term management. And so doing this work, it certainly focused a lot of attention when I was living in New York City in our Asian American communities, but did this in a variety of different foreign-born communities, and found within the African-born communities, we found more than 8% with undiagnosed chronic Hep B infection. So we know that certainly HCC is a major cause of premature death in Africa. Viral hepatitis is the dominant risk factor for HCC in African nations, and that 23% of all individuals with Hep B infection globally reside in Africa. And certainly what at the time when we were starting this, we had a lot of groups engaged in the Asian American space, not many groups really engaged in our African communities, where there's quite a large population in the New York City area. And thinking about the growth of this community over time, and how many people who had not yet been diagnosed, really in my mind said that there was still a gap that we needed to try to address. And most recently, this is data that came out of the Pew Research Center. We now know that 1 in 10 Black people living in the United States are immigrants, and that this has really increased over time. We have more than 4.6 million Black immigrant population residing in the United States, which is projected to double by 2060. And the percent of US Black population who are foreign-born has grown from 3% in 1980 to above 10% as of 2019. And there's certainly a lot of differences among Black immigrants. Those born in Africa tend to have lived in the United States for a shorter period of time compared to Caribbean, Central America, or Mexican or South American Black immigrants. And you can see how graduate level education and median household income kind of falls in between what we see with general US immigrants and US born Black populations. So thinking about, again, a gap in these communities at the time when we started, really shifted our focus from working in Asian American and other communities to really trying to do additional work in the African-born communities living in and around New York City. So with the help of a really wonderful community health worker that was recruited to work in this project and a wonderful relationship with a community partner, African Services Committee, we were able to really focus more efforts in trying to reach the West African diaspora living in the New York City area, test them, get them into care. So really, again, highlighting how community health worker led a model of viral hepatitis outreach could be effective in this community. And we were able to find quite a bit of, again, undiagnosed Hep B infection in these communities. So in developing and thinking about how to build and expand strategies, it's been really helpful for me to think about implementation science and the strategies that can enable community-based intervention. So there's a wonderful publication from 2015 by Powell and colleagues that is often referred to as the ERIC taxonomy of implementation science strategies. There's 70 plus implementation science strategies. I actually went back to that article to kind of look at all of the different implementation strategies that have certainly spoken to me in the work that I've been engaged with community partners. And these implementation strategies include things like building a coalition, creating new clinical teams, developing academic community partnerships, changing service sites, conducting community educational outreach and educational meetings, and creating new clinical teams that might integrate peer navigators and community health workers into those teams, and developing educational materials to advance what we are doing. And thinking about the implementation science approach really has to do with thinking about how we engage stakeholders deeply. And these stakeholders can be at the community member level, community leader level, health provider and health system levels, and then map determinants to implementation strategies, and then adapt or develop models of care from a health disparity standpoint, pilot test strategies, evaluate them, and then kind of go from there. Then we really want to think about what we've done in the African community, and certainly some of the formative work was in identifying barriers around what was happening in the West African community as it relates to hepatitis B, and understanding that barriers when we did this work had to do with limited Hep B knowledge, stigma, fear of disclosure, health-seeking behavior really being symptom-driven rather than preventive, thinking about language barriers, and then trying to think about strategies to overcome these barriers, including developing educational tools, reassurance around disclosure of test results, and preferred understanding what preferred languages and English proficiency look like, and involving community leaders, I would say, was a really important piece of this. So in terms of kind of coming up with an implementation intervention plan, I had the determinants kind of mapped out on the left, and then trying to map them into implementation strategies on the right. I think one of the key components of our implementation strategies that's been very effective in building ties to the West African community certainly has been in developing and establishing a community advisory panel. And these are leaders from the West African diaspora in the New York City area. We meet 2 to 4 times a year. COVID has made us think about more creative strategies, and virtual technology has enabled us to continue these meetings. But really thinking about how we collaborate and share leadership, how we create bi-directional communication and activities, how we solicit feedback and advice, and then really sit together and think about what direction do we want to go in together, how do we develop study ideas and integrate activities better, and then also think about how community leaders can be involved with recruitment of the participants we're trying to reach, and be participants in what we're trying to do. So the current grant specific aims that we have ongoing included test the association of sociocultural factors in West Africans with positive views on Hep screening and intent to undergo screening, with the idea that we take this information and then we develop and refine a group Hep B education program that will then be pilot tested in AIM 3 in the West African communities. to assess acceptability and feasibility. We've also incorporated a behavioral theory-informed approach in community-based participatory research. Here we've used the theory of planned behavior to try to understand what are the domains of influence really around attitudes, knowledge, and perceptions around self-efficacy to understand what then drives intent and eventually screening. And I know we just looked at this slide, but I think this is such a helpful framework. And most of my work, again, has been focused, again, in the individual and community levels of influence and thinking about really where those domains are in terms of behavioral, health systems, sociocultural, and then the community influencers or gatekeepers has been really helpful. And then I'll just end by saying that I've done a lot of rethinking of the role of specialists and how we can be allies in eliminating hepatitis B and rethinking how do we move to non-traditional ways of thinking about our solutions and how we reach communities. And how do we simplify our guidance to increase adoption and adherence? Recognize that there may be training gaps we can help fill. Thinking about how we make care low barrier or low threshold care for communities that have already a lot of barriers. And think about how we advocate, specialists advocating side by side with all stakeholders, I think can be very powerful and being done locally and globally to increase funding and policies to achieve elimination. And with that, I will end with my acknowledgement slide. Thank you.